Good evening. Thank you, Ansari, for this wonderful invitation. It's been always a pleasure to be back here. We missed the whole session because of COVID. There was a gap of about 3 years. Otherwise, Anis sir is also there. It's been wonderful being here. I think it's the 6th time I'm here in SGPJ, and then wonderful. So what I would be speaking on is I would not talk about techniques because we have discussed our techniques to a certain extent during our operative session. So the goals of treatment in an overactive bladder is to optimize the lower tract, optimize the upper tract, and improve the quality of life. So what are the indications where you can always give, where you can give Botox? High detrusor pressures in spite of maximum dosage of anticholinergics, leaks between CIC in spite of anticholinergics, worsening upper tracts, and in cases where there is a decrease in compliance, but there is detrusor overactivity. You can always give Botox into external, where there is external sphincter dyssynergia, more so in female children, even also in males. And there could be sphincter dyssynergia, which could be neurogenic and acquired. So in the bladder, what we could do is in neurogenic bladders, bladder ball dysfunction, we can give along with deflux. Colloquially, that is called detox. And in autonomic dysreflexia, severe autonomic dysreflexia, we can give Botox to the bladder, which also helps. So what are the dosages which are to be given in children? You can choose anywhere between 300, 200, 100 international units. There is no specific guideline today to say that 200 is inferior and 300 is superior. So you need, in a neurogenic bladder, you just tend to pick up around 300 to 200 units. And in bladder ball dysfunctions, you look at 100 international units. How long can you give? You can probably give about 10 to 11 doses, spaced 6 months to 1 year apart. How many sites do you inject? There is no standardization. You can give 10 sites, 20 sites to 40. People have injected even 54 sites. 5 to 10 units per ml. You can do it half an ml, you can do it ml, you can do it intradetrusor is what is recommended. But then taking the adult experience into consideration, you can also give in submucosal plane. What submucosal means is that you should not see that very thin bleb of mucosa. You need to go below the mucosa into the propria, because the basic action of Botox comes with diffusion after you inject. It's not at that point that it actually works. So it also has both motor and sensory actions and it inhibits calcitonin-related peptide and TRP1 and P2X in the urothelium. It can also be used to eliminate pain when there is a sensate bladder and when children have a lot of pain during CIC, and every time the catheter touches the trigone and there is pain, a trigonal injection of Botox is still indicated in these particular situations. So what are the median response of to Botox in different situations? So the median response would be around 7 months in a neurogenic overactivity. In about idiopathic detrusor overactivity is 5.25. So overall, the median response on a gross scale would be anywhere between 5 and 6 months in majority of the cases. So if you are looking at Botox in lower urinary tract dysfunction, non-neurogenic dysfunction, yes, it does improve the number of voids. It increases the bladder capacity. It also improves the quality of life, because all these things, you look at the side effects of anticholinergics, and majority of them are avoided in Botox, but doesn't mean that this is absolutely a wonder drug. So in case of you're looking at the urodynamic parameters, it does improve the Vmax, and P detrusor would definitely come down, and the bladder capacities improve. So what are the parameters which actually improve when you give Botox to the bladders? The maximum bladder capacity can increase anywhere between 37 to 73. Why this so wide variation? The so wide variation is because you're not sure about what kind of bladders you're going to inject, because each bladder would be a separate entity onto itself. Max detrusor pressures would come down by 32 to 52%. Compliance would increase from 71 to 126%. If associated VUR, there is a 73% decrease in grade. We're not looking at total resolution of reflux. There is about 31% resolution of reflux. Fecal incontinence would also improve, more so in cases where electromotive drug distribution of Botox is used in the bladder rather than where it is injected. Only 2 studies from Iran have told us that even an injection of Botox into the bladder improves the bowel dysfunction. Rest have not given us any data on those things. Multiple injections give mixed results. We are not sure about every time you give an injection that it improves. Sphincter injections along with bladder injections are better. The parameters improve, the amount of residual volumes come down much significantly in case of DSDs. Even the newer EAU guidelines, when you look at detrusor sphincter overactive, detrusor overactive and a sphincter overactive, botulinum toxin is a part of the armamentarium today to give to the bladder and the sphincter. No, this is a very busy slide. Let's not look at much of the things. Basically, this is what we are talking about, a comparison of between the botulinum toxin and anticholinergics. So the gist of the whole thing, which has come up in 22 Nature portfolio, is the bladder relaxation is best with Botox at 300, 100, and 200 units. The next best probable drug is oxybutynin, solifenacin, tolterodine, trospium, and tropivarin. So they actually conclude that botulinum toxin should be the first choice in clinical practice. So what are the contraindications to give Botox? First, if you have a thick fibrotic bladder, acontractile bladder, a small capacity bladder, and a poor compliance without detrusor overactivity. What are the adverse effects? UTI, elevated PVR in patients voiding spontaneously, and urinary retention in 1.6 to 2.8% of these children. To summarize, it is safe. Do not give Botox in fibrotic, acontractile, small capacity, and poorly compliant bladders. They do not improve. Presence of an open bladder neck is an independent poor predictor of response to Botox. Intradetrusor and sphincteric injections improves clinical outcomes in cases where there is detrusor sphincter dyssynergia. Deflux plus Botox is effective, but more data is required. Electromotive drug distribution improves both bladder and bowel dysfunction. Again, more data is required. Till date, a maximum of 11 injections have been studied. And these are the papers which you can go through to look at all the data. Thank you very much for your attention.